Ellen. I'm one of the foundation doctors at Sandwell Hospital, and I've got a presentation on thyroid dysfunction. Learning objectives, we're going to describe the features and symptoms and signs of hyper and hypothyroidism. We'll have a look at diagnosing it using blood tests and other imaging modalities. We'll look at formulating investigation and management plans for patients who have thyroid problems and goiters. So thyroid is a gland which sits in the neck. It's located just below the larynx, and it produces the thyroid hormones, which are T4 and T3. T4 is actually produced by the thyroid and is then peripherally changed into T3. The thyroid is stimulated by the anterior pituitary, releasing thyroid stimulating hormone. Anterior pituitary is stimulated by the hypothalamus, which releases thyroid releasing hormone. And the hypothalamus is stimulated and not stimulated by multiple different things. So for example, the cold stimulates it to produce more TRH, whereas stress stops it producing more TRH. The thyroid hormones themselves, T4 and T3, both have negative feedback systems on the anterior pituitary and the hypothalamus. So hyperthyroidism is where the thyroid is producing too much thyroid hormone. There can be primary causes, which is where there's a problem with the thyroid itself, or secondary causes where the thyroid is being stimulated by too much thyroid stimulating hormone. So the types of primary hyperthyroidism include Graves' disease, which is an autoimmune condition. The autoimmune stimulates the TSH receptor in the thyroid to produce more thyroid hormones. There's also thyroiditis, which is just inflammation of the thyroid caused by a virus. It's transient, lasts a short amount of time like any viral symptoms. And the patient can also have a temperature and they'll get pain in their neck where the thyroid is. You can also get toxic multinodular goiters. These often occur in the elderly. They don't come with the specific Graves' disease symptoms though. Secondary causes, so too much TSH can be caused by drugs such as amiodarone, lithium, or iodine itself can cause primary where it stimulates the thyroid to produce too much. Carcinomas of the pituitary can cause too much TSH as well, or exogenous release of thyroid hormones or TSH can be, for example, ovarian germ cell tumours. So signs and symptoms of hypothyroidism, I like to think of everything working overtime. The thyroid is overactive and everything else is overactive. This means that you lose weight, you're too hot, you sweat profusely, your bowels are overworking, you're getting diarrhea, you're tremulous and anxious, your heart beats too fast. You also get hair thinning, you do get a goiter, you get brisk reflex and you're irritable, and you can get proximal myopathy as well. Specific symptoms of Graves' disease can also occur in patients who have Graves'. There are many eye symptoms such as exophthalmos, where the eyes look like they're bulging. You can get ophthalmoplegia, the eyes don't move the way they should. You can also get pretibial myxedema, which is an infiltrative skin condition where you get waxy discoloration, induration of the skin, and it looks a bit like orange peel. You might also get a diffuse goiter and splenomegaly. So there are multiple blood tests you can do to diagnose hypothyroidism. So the first set, you do thyroid function tests. So in someone with hypothyroidism, they've got too much thyroid hormone, and we measure that as a raised free T4. So T4 can be free in the body, but lots of it is actually bound to thyroglobulin. We don't normally measure T3 levels. Only measure that if T4 is normal and you're still suspecting a type of hypothyroidism. You then look at the thyroid stimulating hormone. If it's a primary cause of hypothyroidism, where the thyroid itself is producing too much thyroid hormone, the thyroid stimulating hormone levels will be low, because if you look in the diagram next to it, the T4 and T3 have a negative feedback on the anterior pituitary, so it will try and produce less TSH to stop the thyroid making so much T4 and T3, but it's the thyroid that has the issue. It doesn't listen to the TSH and continues to produce the T3 and T4. If someone's got a secondary form of hypothyroidism, for some reason, there's a lot of TSH, which is stimulating the thyroid to produce the T3 and T4. So TSH level in secondary is high. You can also look at autoantibodies, such as antimicrosomal antibodies or TSH receptor antibodies. These are often present in Graves' disease. They work against thyroid peroxidase. Most patients with hypothyroidism will get goiters. There are different types of goiters. Diffuse, which is where the whole thyroid itself swells and enlarges. Multinodular, where there's lots of nodules on the thyroid, which all overproduce thyroid hormone. Or uninodular, where there's just one nodule overproducing thyroid hormone. And depending on the type of hypothyroidism you have will depend on the type of goiter that you might get. You can feel somebody's goiter as a type of diagnosis of what the goiter might be, whether it's diffuse or nodular. Be able to feel those nodules. But often an ultrasound scan can be used, or a CT scan, to look at the type of goiter someone's got. There's also thyroid uptake scans, where you ask somebody, they drink some radioactive iodine, and because the thyroid uses iodine to make T3 and T4, you can see where in the thyroid itself is using most of that iodine, which, because it's radioactive, it's showing up on those images. If it's all over the thyroid, it'll be a diffuse one. If it's in multiple patches, it'll be multinodular goiter. If there's just one area of really high iodine uptake, that's the uninodular, often caused by a tumour, an adenoma, or a cyst. So management of hypothyroidism. So patients might need symptom control. That can include beta blockers if they're finding that they're very tachycardic all the time. Beta blockers can help them with some of their symptoms. Mostly patients take antithyroid drugs such as carbimazole or PTU. PTU is generally reserved just for patients in pregnancy, or if they have a thyroid storm, it's used. When patients taking carbimazole, once they're euthyroid, so their thyroid levels are back to normal, the dose is reduced to as low as it possibly can be, while still making sure that the thyroid levels are in range. Another option is radioiodine. So like I said, the thyroid uses iodine. So if you ask a patient to drink radioactive iodine, it goes to their thyroid and then begins to destroy the thyroid glands, so it can't make as much thyroid hormone. You're meant to stop taking your antithyroid drugs about a week before the radioactive iodine. And it's normally used in patients where the antithyroid drugs haven't worked, or they're not taking the medication as they should, or often in toxic multinodular goiters, the radioactive iodine is quite useful. If none of these are working, there are surgical options where you can have a subtotal or a near total thyroidectomy. That's where you remove part or all of the thyroid itself. You then might have to stay on medications after removal of the thyroid, so you take thyroid replacement after that. Patients, when they have their surgery, need to be euthyroid at that point to prevent them from getting something called thyrotoxic storm. So the other condition is hypothyroidism. This is where the thyroid is underactive and you don't have as much T3 and T4 as you need. Again, there are primary and secondary causes depending on whether this is a problem with the thyroid itself or a problem with something else which stimulates the thyroid. Hashimoto's thyroiditis is an autoimmune type of hypothyroid. It's associated with a painless diffuse goiter. There's also atrophic thyroiditis, which is also an autoimmune cause. Iatrogenic causes include radiotherapy to the neck. For example, if a patient has lymphoma, the radiotherapy could damage the thyroid and prevent it from making the thyroid hormones. You could also, as I said before, patients who have had surgery to remove their thyroid due to hyperthyroidism then get hypothyroidism and need to be on thyroid replacement. Iodine deficiency is actually the most common cause of hypothyroidism worldwide. But as well as that, too much iodine can actually lead to autoimmune thyroiditis. There are multiple different congenital causes, such as an absence of a thyroid or a malformation of the thyroid. These are quite rare. You can also get infiltration of the thyroid from things like sarcoidosis or amyloidosis. If they have deposits in the thyroid can't function as normal. And then there's also normal thyroiditis, which is the viral thyroiditis we were talking about, which can cause hyperthyroidism, can actually also then go on to cause hypothyroidism after the hyperthyroidism. They can also get thyroiditis in after giving birth. Pregnant women can get it after giving birth. Secondary causes of hypothyroidism include hypopituitarism. So if the anterior pituitary isn't making the thyroid releasing hormone, you won't get enough T3 and T4. You can also get hypothalamic disorders. There could be a tumour or trauma to the thalamus itself, hypothalamus. Signs and symptoms. This is the opposite of hyperthyroidism normally. So I like to think hypothyroidism is where some things aren't working properly, they're all slowing down. You haven't got enough of the T3 and the T4. Things are slowing down, your metabolism's slowing down, so you get weight gain, you're all cold, your bowels stop working properly, you get constipated, you're a bit sluggish with your memory and your concentration, you're dry, you lose your hair, you're tired, you're lethargic, you get bradycardic, you're cold, and you get delayed reflexes. Everything's slower in hypothyroidism. So again, blood tests used to diagnose hypothyroidism. The thyroid function tests. You look at the thyroid stimulating hormone, and similarly to hypothyroidism, they might be raised or lowered depending on whether it's primary or secondary. And you'll get a free T4 level as well. If you have a low T4, that means you have hypothyroidism. If it's a normal T4, you might still be at risk of developing hypothyroidism if you have a raised TSH level. There are autoantibodies which you can look at. These include anti-TPO, which is antithyroid peroxidase, and antithyroglobulin. These are present in the autoimmune types of hypothyroidism. Other bloods to look out for: patients who have hypothyroidism can also get a raised CK. They might have a raised cholesterol and triglycerides and anemia as well. Managing hypothyroidism is slightly simpler than hyper, in that you just need to replace the thyroid, replace the thyroid hormones that you are lacking. So this is normally done by levothyroxine in primary hypothyroidism. You have to regularly monitor TSH levels. This is every 3 months until the T4 levels are stable, and then you can measure it yearly. Symptoms do tend to take a few months to resolve after starting the levothyroxine. Drugs such as ferrous sulfate, calcium supplements, rifampicin and amiodarone can interfere with T4 absorption. So you should look at if a patient is on those medications and if that could be causing the hypothyroidism. Also look at the cause of the hypothyroidism. If there's a tumour or a deficiency, see if you can change somebody's diet, or obviously treating that tumour or that cyst which is causing the issues. In pregnancy, women need to be euthyroid before they get before they get pregnant, and TFTs need to be monitored in each trimester because levothyroxine may need to be increased in pregnancy. In older patients as well, and patients with cardiac disease, they should probably have lower doses of levothyroxine and regular monitoring of TSH and T4. So, in summary, we've been through hyper and hypothyroidism. We've also looked at different types of goiters. We've been through some of the causes, their main symptoms to look out for, how to diagnose, including looking at the blood tests and different imaging modalities when looking at goiters, and the different management options of hyper and hypothyroidism. Thank you very much for listening to my presentation. I hope it's been helpful. Thank you very much.